In this presentation, we're going to provide an overview and high-level introduction to burns, what they are, how they're cared for, and what we can do in the fire service to deal with them when they're encountered. This is intended as an introduction, kind of continuing education material for the fire service. Obviously, EMS, other healthcare providers, follow your own protocols. This is more for the fire service. Let's talk overview of what we're talking through today. First and foremost, fundamentals of burns, what causes them, signs and symptoms, and some of the basics on assessment. Then we'll go through how to care in a pretty high-level general sense. Obviously, can't get too hands-on with this remote learning option. Objectives, learn the fundamentals of burns, including common mechanisms, learn how to assess injured, burned patients, and then how to care for those burned patients. All right, fundamentals of burns. Broadly defined, burns are damage to tissue, typically skin, but it can be more internal, particularly with things like chemical burns or really deep heat-related burns. But generally, it's going to be skin. Burns can be caused by heat, cold, electricity, chemicals, friction, even ionizing radiation, things like that. Lots of different causes, all sorts of ways the tissues are damaged, not purely mechanically. They're either brought to too high of a temperature or otherwise destroyed in their ability to function. So causes, thermal is kind of one big cause, electrical is another big cause, chemical is another big cause, and then friction and radiation are really pretty secondary, pretty minor. Not super common to see radiation burns out there, but they are technically possible, and some businesses should be more concerned. Most of the fire service, not super concerning to us. Thermal burns are the most common kind of burn to happen, and really kind of the simplest one that we all think about when we hear a patient has been burned. This is caused by the direct or indirect exposure of tissue to high temperature. High temperature can be in any number of forms. Most commonly going to be something like fire or a hot pan or something like that. Can also be caused by hot liquids as well. So most common cause of burn statistically in the United States, about half of those are attempts to light a fire. I would be willing to wager that a significant portion of those are males, probably between about 10 years old and 40 years old, trying to light a fire with something like gasoline. Super common, actually, especially getting into the summer. Can have incidents with fireworks, things like that. Thermal burns obviously also caused by structure, wildland fires. Your wildland fires, you can have them where guys are stepping into stump holes that are burned out. Looks like regular ground, but it's a burned hole of stump, and there's a bunch of hot material in there that's still burning, and then firefighter gets burned on the boot and ankle. Thermal burns also include scalds. Scalds are broadly defined as any thermal burn caused by a hot liquid. This can be a hot drink, coffee, tea, things like that. Think about that person who got burned at the hot coffee at the McDonald's. Can be caused by bathwater, especially with children under 5. If they get into a super hot bath, they can't sense the temperature nearly as quickly, while adults can. Also caused cooking oil, steam. Steam is defined as a scald, even though it's doubtful if you can call it a liquid or not. That's all in there. Common for kids under 5. This can also be that mechanism where there's a pan on the hot stove, especially if there's cooking oil or something like that. Kid reaches up, grabs the handle, pulls it off the stove. They get a burn pattern on their head, then down onto their shoulders. That's possible as well. That's all classified as a scald. Electrical burns are tissue damage from the pathway that the electrical current uses to pass through the body. So kid sticks a fork in an electrical outlet, he's going to probably get an electrical burn. Same with lightning. That's an electrical burn kind of injury. Can also happen with an arc flash, but that's really not part of this. It's its own kind of broad category underneath of electrical burns. Electrical burns are broken down with voltage and then flash or not flash. So high voltage is greater than 1,000 volts, 1 kilovolt, or less than 1,000 volts is low voltage. Amperage is not important, it's the voltage. Flash burns caused by an arc flash, different category. They're kind of weird and they behave more like what you would see with someone lighting off a flammable gas or gasoline or something like that in a space. You'll see broad burn exposure on the area that's facing that panel. Not as much as like what you see on this figure on the right. That's direct burning from electrical current making entry to the body right there. Most common cause is cords. So if someone's got a frayed electrical cord, this can cause an electrical burn. Same with outlets. So you got a hole or someone sticks something into an outlet, they're going to get a burn. Lightning as well does this. What's important to know with electrical burns is you can see secondary injuries in addition to that burn. When the electricity enters a person's body, that causes a broad muscular disruption. May be localized, may be much broader if the voltage and amperage is high enough. That can cause muscle to violently contract, totally disorganized, kind of like a seizure, but it's as if all the muscles are being given the command, seize up 100%. This can be often strong enough that it'll cause fractures, even in long bones, things like femurs and things like that. So there can be injuries like that secondary to electrical injuries themselves. Obviously, you can also have cardiac arrhythmias, kind of cardiac issues that go with electrical burns, lightning strikes, things like that. You can expect that, especially if the current appears to have passed through the torso. So you've got an entry wound. Electrical burns typically will have an entry wound and an exit wound. Entry wound where the fork went into the outlet, exit wound, the foot that went to ground. So you have an electrical pathway then that goes through that person's arm, through their torso, down the leg, out the foot. Look for injuries, obviously, hand and foot. Also think about a cardiac issue or something like that because that current pathway went through the chest. Remember, the heart is powered by electricity. It has circuitry in it, and disrupting that electricity is a big problem with how the heart functions. Chemical burns are caused by exposure to chemicals. Not any chemicals. This is going to be an acid or a base, typically a strong acid or a strong base. So this would be something with a pH less than 5 or greater than 10 as a broad kind of category. Hydrofluoric acid, sulfuric acid, hydrochloric acid, sodium hydroxide, lye, all of those kind of common names are what you would see as things that would cause chemical burns. These are typically secondary to ingestion. So someone drinks a caustic liquid of some variety. This is going to do damage with chemical burning to the inside of the patient's airway, trachea, esophagus, etc., upper airway kind of space. There's a super high risk of mortality with these patients if there's any airway damage. You can expect a great deal of edema showing up really quickly, and this can cause the patient's airway to close up pretty quickly. These patients do need gross decontamination. So if you've got powdered acid or base material on someone, obviously don't use liquid, but if someone's been splashed by an acid or base, you're going to do a gross decontamination and flushing them with copious amounts of water. This is a good use for a booster reel. This is a good use for a bumper line, something like that. You want easy to pull out and just dump water onto them. Something like 15 minutes is what's recommended to make sure that it washes all that acid or base out. Doesn't have to be super high pressure. Don't get all pump engineering on it. Not a big deal. Just flowing water and flow a lot of it. Let's talk degrees, thicknesses, how these are classified. Degrees and thicknesses it's fundamentally interchangeable. Superficial or first degree burn is going to be the most common type. This is more like what you would see as a sunburn. I think we're all pretty familiar with a sunburn here and there inadvertently. Superficial burns only affect the outermost layer of the skin. So they're going to be red, they're not going to be any blistering, they're going to be dry, no fluid leaking out of the skin. The skin's just kind of mad and unhappy that it's been exposed to too much sun, too much heat, something like that. And they are pretty darn painful. We've all been sunburned. We know that it's not a fun experience. Looking at a partial thickness burn, though, this is more of a second degree burn. Note that big blister that shows up on that patient's hand. That blister is really the diagnostic factor between a superficial and a partial thickness burn. So you'll see some redness around the periphery of it, and then a pretty clear looking blister. It's not blood, that's lymphatic fluid, just interstitial water that's filled in that space to cushion and effectively try and cool the burn. That can start to leach out, and you can have moist or somewhat moist skin tissue around that. These can be pretty painful, especially around the edge of it, or if there's any pressure or discomfort on it. As soon as you push on this, it's going to hurt a lot. So as we get more significant on the depth, severity, how big of a deal the injury is, we get into the full thickness burn, so 3rd and 4th degree. Full thickness 3rd degree burn is where the tissue is burned all the way through, at least the skin is burned all the way through. So this image on the left side is a full thickness burn. You see we're through the skin into the tissue below, presumably some fat and a little bit of other kind of tissue around the bottom of the foot there. It's going to be stiff. I mean, that skin has been damaged significantly, white to brown color, so you can kind of see it, you know, it's real damaged, hardened up. It can be kind of leathery texture. The burn itself is painless. That's because the nerve endings that come into the skin have been destroyed. However, you see the fringe of that is still 2nd, then going into 1st degree burn. That's going to hurt a lot. So this patient is not in no pain. They're still going to be experiencing some pretty significant amount of pain with that kind of burn injury itself. Going to the 4th degree, this is the more significant, past that initial 3rd degree full thickness. You see this is where tissue below the skin has been damaged pretty severely, and we see those are the bones of those fingers that are sticking out through the tissue, and those are what are left after exposure. So I'm not exactly sure what happened to this guy, but he's pretty significantly burned on that hand. So 4th degree burns where we don't have tissue really anymore, or it's been blackened, charred with some dead tissue. It's dry and painless. Then as we go down, you'll notice all of the blistering and that swelling that's happening on the hand. So this part up here with the fingers, that part's painless, but this part is all 2nd and 1st degree burn, mostly 2nd degree burn. That's where the real pain is going on. That's still a big deal, and that's still an issue. Obviously, there's a great deal of damage that's done, but this is still going to hurt a lot and be a problem. So your signs and symptoms of burns, pretty obvious: burned or damaged tissue. Be that you obviously see the burn, or you know that the patient has trauma that was caused by a mechanism that can cause burns. So lightning strike, they were in a fire, they were exposed to an explosion, natural gas explosion, car blows up after a crash with a big fireball. Look for burns, arc flash, that kind of thing. Also look for signs of hypovolemic shock. That's something to kind of expect as a later sign with more significant burns, something to think about and be alert for. It wouldn't be a primary indicator that the patient's been burned. Symptoms, most likely pain. There's very, very low likelihood that the only bit of burn they have is going to be 2nd, 3rd, or is going to be 3rd or 4th degree. There's going to be 2nd and 1st degree burns around that. They're going to be in a lot of pain. You can also see altered mentation as that patient starts to go into hypovolemic shock, as the blood is losing water to try and deal with that burning area. That's going to drop their blood volume and be a significant problem, driving them into shock itself. Also look out for shortness of breath, wheezing, hoarseness, stridor, or itchiness. All of these are signs of airway involvement. As soon as you're seeing any of that wheezing, hoarseness, things like that, look real closely at the patient's nose and mouth. See if there's burned nose hair, burns inside of the mouth, things like that. That's all a very, very significant finding. It can make a burn. Minor injury, no big deal. We're still going to the hospital. Can turn into we're going emergent or considering flying this patient to the hospital because of that airway involvement. When we assess a burn patient, obviously find the burn, identify where it is, what caused it if we possibly can, and then figure out the area that it covers. So that's the percent of the total body surface area, or TBSA. This can be assessed with what's called the rule of nines. Find a chart somewhere. Basically, you can divide up the body into even multiples of 9 as each limb, portion of the torso, things like that. They all sum up to percentages. The easy way to think about it is the patient's palm is 1% of that patient's total body surface area. So whatever you can cover with one palm from the patient, not your palm, not some other guy's palm, the patient's palm is 1%. Figure out the percent covered, figure out what degree is covered by what percentage of area. So patient's been exposed to fire, they've got 5% at second degree and 5 additional percent at first degree. Cool, document that, have that written out. Look for those respiratory status changes, any hoarseness, any obvious sootiness in their nose and mouth, singed nares or soot in the mouth itself. Think about what caused the burn, if there's anything else going on, and obviously take vitals. Reassess these patients routinely because there's a significant potential for them to go into shock. So let's look at critical burns. Second degree burns greater than 30% of the total body surface area. Third degree burns greater than 10% of the total body surface area are critical just by how much area is covered. That means that there's a propensity for them to go into shock. Any respiratory involvement or burn to the face is a big deal. Obviously, you get sunburn on your face, that's no reason for a helicopter ride to a trauma center, but if there's a real burn injury, especially if they go into second and third degree burns on the face, that's a big deal. Any associated significant injuries. So electrical burn that also comes with fractured leg because of a violent muscle contraction. That's a critical burn. Any electrical burn, primarily because of that cardiac involvement and that cardiac risk, that's critical. Deep chemical burns. So if it's gone beyond a basic first degree burn and there's chemicals involved, that's a critical injury in and of itself. That needs to go to the hospital pretty quick. Remember to decontaminate that patient. Any patient with an underlying history, cardiac issues, diabetes, anything like that, that's going to make it more significant. Anyone below 10 or above 50 just kind of is a complicating factor in and of itself. So treatment. Treatment is first and foremost stop the burning. For those of you in the Denver metro area, which should probably be the audience of this, take a look at protocol 8130. Get on the app, pull it out, have it in front of you, follow that. If you're not following the Denver metro protocols, follow whatever protocols are relevant, whatever. Denver metro 8130, take a look at that and see what flow you need to go through. A lot of this information's in there for you, so you have something good to look at. First and foremost, stop the burn. Their clothes are burnt, remove them. If they're actively burning, put the fire out. Simple, obvious stuff, but don't get into advanced assessment trying to start an IV, any of this fancy stuff if the patient is still on fire or if they need to be decontaminated. So once you stop the burning, go to respiratory. Is there an issue with their respiratory system at all in any way? Especially if they've been exposed to fire, hanging out in conditions near a fire. Consider that high flow oxygen, just get it going. Take care of that oxygenation hard and fast immediately. Then also think about carbon monoxide and hydrogen cyanide poisoning, that's CO and HCN, if the patient's been exposed to any kind of fire conditions. Those can be a real comorbidity. They can have some burns. Yeah, okay, they were in a fire, we don't really know what's going on, but they're kind of starting to circle the drain. The burns aren't that bad. Oh wait, they're not getting any oxygen on board because they have carbon monoxide poisoning. So worry about that and assess it as best as you can. Then take action to see if this patient's critical, non-critical. So go through that assessment, see what's going on. After we determine if they're critical or non-critical, we go to fluid resuscitation and immediate transport. So supporting care, once we've taken care of those initial things, just your regular trauma care. Whatever you need to do to mitigate whatever other issues are present, take care of that. Stop bleeding, splint, broken bones, things like that. Remove any rings, belts, or other constricting items, especially if they're somewhere where the patient's been burned. That's going to cause a real big issue if that area starts swelling, really when that area starts swelling. It can cause a compartment syndrome and be a real big deal. Dress burns with a dry, sterile dressing. No need to wet them down. No need to use any of those burn gels. Those really aren't recommended, at least in the Denver metro system. Use dry, sterile dressings. We're trying to prevent infection. We're trying to keep them from getting cold. So grab that emergency blanket, wrap them up, keep them warm, and then monitor that patient for the whole transport. Standard ABCs, watch that mental status and SpO2. Mental status in particular is how we're going to know if they're going to start to go into shock. So fluid resuscitation. If the patient is critical, then we go into this fluid resuscitation mode. What's important to know, there used to be the Parkland formula and this whole complicated, take the percentage and multiply it by the number of kilograms and then multiply by the square root of E, or some complicated nonsense formula that basically said give them a lot of fluid really, really quickly. That's all probably reasonable. That's no longer the recommendation for us in the field. Our orders in the field are if the patient is critical, so those critical criteria that were laid out earlier, pull out your protocols, this is in there. If the patient is critical, then we go to fluid resuscitation. We're using normal saline or lactated ringers for adults, normal saline for kind of that middle pediatric, and anyone below 5, they can get D5W normal saline or lactated ringers. We're going to give 500 milliliters per hour of normal saline or lactated ringers for anyone over 14 with those critical burns. 250 for anyone 5 to 13, 125 for anyone below 5. That 125 is going to be not a continuous administration. We're going to be paying attention for any fluid overload with them. The recommendation is 250 as what you're giving for 30-minute pre-hospital time. So transporting the patient about half an hour, we're giving them about 250 total. 2 large bore IVs, get them started in the field, get them ready. AC is the best way to go. Hands, remember you can't get as much into those. Try and get both ACs if you can, something like an 18. Not critical, no need to flood them with fluids. This can cause problems with the lungs, waste our fluids, and it really doesn't help that much. But if they are critical, you're seeing those signs of hypovolemic shock, go ahead and start getting fluids on board. So, questions, any comments, anything like that, put them down in the description or the comment section. We'll see what we can do. Remember, follow your local protocols. This is based on the Denver Metro protocols. Don't supersede whatever you're doing based on what we're doing here. And otherwise, be safe and put the damn fire out. That's the first priority with any burning patient. Stop the threat, deal with that, make the scene safe. Thanks all.